Welcome back, everyone. Check. My name is Dr. Rishi Ganesan. I'm a pediatric critical care physician researcher from Canada, and I have the pleasure of being the chair for this oral presentation session on the pediatric topic. Originally, we were supposed to have 5 presentations. Unfortunately, we don't have Dr. Dalia Abdul Rahman here from Egypt. So if we have Alet Koopman from the Netherlands, we can get started with using surface electromyography of parasternal intercostal muscles and diaphragm to quantify patient-ventilator interactions.
Okay, thank you, Chairman, for this introduction, and thanks to the organizing committee for giving me the opportunity to present the study here. I have nothing to disclose. So this is a very interesting figure of the concepts of lung protective ventilation and diaphragm protective ventilation. These concepts aim to protect the lungs, and they aim to minimize the stress on the diaphragm. It is suggested to adjust the mechanical ventilator to modulate the patient's inspiratory effort and to minimize the dynamic lung stress and to prevent asynchrony between the patient and the ventilator. Patient-ventilator asynchrony can induce lung injury and diaphragm injury by increasing the dynamic lung stress and injurious diaphragmatic contractions. Patient-ventilator asynchrony is defined as a mismatch between the patient demand and the delivered ventilatory support at any moment during the respiratory cycle. It has a high incidence in pediatric mechanical ventilation, with 1 out of every 3 breaths being asynchronous. Patient-ventilator asynchrony can be a marker of the disease severity, or it can result from inappropriate settings. To quantify the real patient-ventilator interaction, the neural drive to breathe of the patient should take into consideration. So in our previous research, we used the surface EMG of the diaphragm as a surrogate of the neural activation of the respiratory muscles. So, it was too quick. In the above tracing, we have an example of a good patient-ventilator interaction with every neural breath is succeeded by the ventilatory pressurization. And in the lower example, we have an example of the poor patient-ventilator interaction with the ventilatory pressurizations occur more frequently than the neural activation of the diaphragm. But what about the parasternal intercostals? The parasternal intercostals are obligatory muscles of inspiration, and in our last research, we have showed that there's a difference between the activation of the muscles between the diaphragm and the intercostal muscles. When the inspiratory load is increasing. So this brings us to the aim of the study. The aim of the study was to evaluate the agreement between the patient-ventilator interaction using surface EMG of parasternal intercostal muscles and the diaphragm in invasive ventilated pediatric patients. It was a prospective observational study in a tertiary pediatric intensive care. All patients who were mechanically ventilated were eligible for inclusion. We had a few exclusion criteria. Every included patient was recorded for a continuous measurement of 5 minutes of the ventilatory waveforms and the surface EMG of the diaphragm and the intercostal muscles. 2 electrodes were placed bilaterally at the costo-abdominal margin in the nipple line, and 2 electrodes were placed in the second intercostal space at the right and left. The obtained onset of the inspiration and the obtained onset of the ventilator, then we could define the trigger error as the relative timing difference between the onsets and the cycle error as the relative timing difference of the termination of the inspirations. Breaths were defined as synchronous when the trigger and cycle errors were below 33%. They were defined dysynchronous when the trigger and or the cycle error was above 33%, and breaths were defined asynchronous when there was no relation between the inspiration of the patient and the ventilatory pressurization. We had 5 types of asynchronous breaths. It was the case when there was only ventilator pressurizations, only inspiration of the patient, when there were multiple ventilatory pressurization with just 1 inspiration of the patient, multiple inspirations of the patient and 1 ventilatory pressurization, and when it was totally chaotic with multiple patient inspirations and ventilatory pressurizations. To quantify the patient-ventilator interaction, we calculated the EMG-SYNC index. In total, we included 35 patients with a median age of almost 5 months, and 31 were admitted to the PICU with a pulmonary diagnosis. In total, we made 78 recordings, and almost all recordings except 1 were made during pressure-controlled, assist-controlled ventilation. The EMG-SYNC index was not significantly different between the parasternal intercostal muscles and the diaphragm. When we take a look at the type of the breaths, majority of the breaths were desynchronous. So it was 66% for the diaphragm and 77% for the intercostal muscles, the median rates. And the median rate of the asynchronous breaths were 14% for the intercostal muscles and 25% for the diaphragm. When we take a look at the types of the asynchronous breaths, the majority of the breaths for both muscle groups were only mechanical ventilatory pressurizations. So can we explain this? Because it may suggest that the ventilation was with high pressures or a high set frequency, which may induce overinsistence, and that reduces the patient's inspiratory drive and there by the exhibitive reflexes. The correlation, we had a strong correlation between the EMG-SYNC index of the intercostal muscles and of the diaphragm, but not perfect. So it may suggest that the EMG of the diaphragm and the parasternal intercostal muscle is not interchangeable. When we take a look at the breath-by-breath analysis, we saw a poor correlation between both muscles, so for the trigger error and for the cycle error. And we expected that most of the breaths were in the upper right quarter or the lower left quarter, but there were a lot of breaths in the upper left quarters for both the trigger error and the cycle error. So these breaths were characterized by a negative error for the diaphragm and a positive error for the intercostal muscles. Can we explain this? When we take a look at our tracings, so this is a tracing of a very small part of 1 patient, we saw that the diaphragm and the intercostal muscles were not in synchrony. So the intercostal muscles triggered the ventilator, and the diaphragm is totally out of sync with the ventilator and the intercostal muscles. We had some limitations. It was just a single center study. Our study population was it was young. The predominant mode of ventilation was pressure controlled, assist controlled, and to date it's not clear if the mode of ventilation could affect the incidence of patient ventilator asynchrony. Surface EMG has some practical limitations, so it's very susceptible for noise and artifacts. We cannot avoid it, but by post-processing and by analyzing the signals, we could minimize the effects. And in 17 recordings, we had no muscle activity in the parasternal intercostal muscles. So this can be because of inactivity of the muscles or because of a low signal-to-noise ratio. For future research, we would like to investigate the time course of the patient-ventilator interaction using our signals. And there are no clear definitions on the onset and the termination of the neural inspiration using surface EMG. So we more or less adapted the definitions of 80 of the transesophageal measured signals. But we have to investigate if we have to make new definitions or we just can adopt these definitions. In conclusion, where feasible to quantify the patient ventilator interaction using the surface EMG, and monitoring of both muscles is needed for accurate evaluation of patient ventilator interaction. So, thank you.
Thank you, Ellen. It was a wonderful presentation. We'll take the first question, Peter.
Thank you, Annette, for this presentation and interesting concept of using surface EMG. May I ask first a question? Where did you put the surface EMG? On which level? Did you use 3 levels, kinetic, intercostal, and the diaphragmatic level, or at which level exactly? Or did you only on the diaphragmatic level?
We did put electrodes on the costal abdominal margin, so at the diaphragm level, and in the second intercostal space for the intercostal muscles.
And you showed the combined signals?
No. We just analyzed and the intercostal muscles and the diaphragm separately.
Yeah, but on the diaphragm, you did not have the navasond in just the surface?
Yeah, just surface.
Okay.
Yeah.
So why would you expect that on the diaphragmatic level you're in phase with the intercostals on the scalenic?
I'm sorry, what was
Why would you think that the diaphragmatic would be in phase with the scalenic muscles? If you look at physiology of breathing, you breathe first with diaphragm and then you add on top the intercostals upwards.
Yeah, so we did it because we had, before we started this study, we had some measurements that both muscles were totally out of sync. So we thought maybe it's not the diaphragm that we measured, but it were abdominal muscles of expiration. But in some patients, we saw they were totally out of sync, and it was not the abdominal muscles. I didn't put it in the presentation, those signals. So we could not understand why these muscles were totally out of sync. I agree that they are succeeded each other, but the total out of sync, I can understand.
And did you see a variability of this phase delay from patient to patient, or was it always the same behavior because your blood does not give us the details on this?
Yeah, we did not look at that yet.
So you do not know if some patients have a big phase difference, the other ones are?
No.
Would you have the ability to look at this?
Yes.
Would be great to know.
Yeah.
Thank you.
Any other questions? I have a question just along the lines of what Peter said. So in terms of looking at the different levels of intercostal muscles, is there a plan to compare the different levels? For example, lower intercostals versus the upper intercostals, or anterior versus posterior? And do you think that is going to give you more information, or along the lines of what Peter was saying in terms of the natural progression of this muscle activity spread?
We just worked on a consensus paper with a whole group of experts from all over the world, a consensus paper of surface EMG for the respiratory muscles. And in this paper will describe that we agree that it gives the most information when you just measure in the second intercostal muscle space.
If there are no more questions, thank you very much for your presentation. With that, we will move on to the next presenter. It's a very interesting talk, relevant and timely in terms of the hypoxemia and the hyperoxemia debate that's going on in the ICU world. Association of severe hyperoxemic events and excess mortality in pediatric critical care, an observational study. And to present this, we have Tom Bachman.
Instructions on the, okay. So I'm really delighted to be here to share our work. It's a single center observational study looking at hyperoxia as defined by blood gases with excess mortality. And it's like I said, it was an observational study. Now let's see if I can make this slide move. Oh. Okay. I'm with the Czech Technical University in Prague. I also have a consulting business in the United States, Metrix, and I have no competing interests in this research. Don't have to turn around, I can look there. Good, I was looking out there. So in the context of the pediatric ICU, there's emerging awareness that hyperoxia has an impact on outcome. That's not new to neonatologists, and adults have been studying it maybe a decade ahead of the pediatric ICU. There is some observational data in the pediatric area that shows that admission hyperoxia, measured different ways, is associated with excess mortality. And there is a single observational study that suggests that any hyperoxic events during mechanical ventilation subsequent to admission are associated with excess mortality. That study by Ram Gopal was published in 2019, and you can see, I'll try the laser here. Oops, the laser, here we go. You can see the dark green are the estimated mortality based on the PRISM score, or they used a different estimate actually, not the PRISM. And then the light green are the observed mortality, and they found that 300 and higher, there was a highly significant difference, and that multiple episodes had a compounding effect or a dose response type effect. Our goal in this first step in this research was to confirm that association, that a high PaO2 measured by blood gas was associated with excess mortality. We're doing it in a single database from a single hospital, CHLA. it's pediatric and cardiothoracic patients, and we used a prospectively designed analysis of an existing observational database. Before I get into the details of the study, there's another point I want to make. There is one observational report that high SpO2s, cumulative exposure to high PaO2s, is associated with admission is associated with subsequent multi-system organ failure, and that was just published, and there's an ongoing study. In fact, the enrollment is closed. The results aren't available, but they'll certainly be available this year. A large multi-center randomized trial comparing management with a high and a low exposure to hypoxemia based on the saturation control. So we'll have that information later this year, I'm quite sure. Now, back to our study. This is the Children's Hospital in Los Angeles. The database is from the cardiothoracic and general intensive care units. There are 6,000 admissions in this database from a 10-year period, and we have 90,000 paired ventilation and blood gas measurements in the database, along with a whole bunch of other things. Our method of analysis was a regression approach, a logistic regression, because we looked at ICU mortality as the primary endpoint. The independent variable was, as I said, this event of a high PaO2, and we controlled for other confounding variables, covariables. And those were which ICU were you in, the pediatric or the cardiothoracic, the PRISM-3 score at submission, and then aberrant blood gas measurements, a very low PaO2 or a high or a low pH. And then we also controlled for, or considered controlling for, the number of blood gas measurements that was used as a marker of severity that Ramgopal had used in the other study. And we excluded all the subjects that had less than 1 day of mechanical ventilation, all those that were exposed to ECMO. That left us with a population of just over 4,000 admissions and 71,000 paired blood gas measurements. In the population then that we did the analysis, the ICU mortality was 8.1%. The PRISM predicted mortality was 6%. And the covariates, those with asterisks, the PRISM and which unit you were in, high PaO2 and a low pH, and the number of blood gases were all on a univariate analysis statistically related to mortality. Within the population that we studied, again, they had a median time on mechanical ventilation of 9 days, between 5 and 16, the interquartile range, and the highest PaO2 that patient population saw on average was 141. So this is the excess mortality compared to the highest PaO2. So we have the highest PaO2 the patient saw here. So these never saw PaO2s above 100, and these were the higher ones. And this is a binomial regression of individual data, and you can see there's a very marked U or J shape, depending on how specific you want to be, effect here in general. When we split it into quartiles, you can see that there's a few patients, about 14% in this category, and about 10%, as I was on the previous slide, in the high category, and most of the patients then are on these highest PaO2s, less than 200. And then rather than go through this, I have a chart that'll show it better. You can see here the red values are the observed mortality. The blue is the predicted by PRISM, and then these calculated red are for each of 4 quartiles, the predicted mortality, and it is also U-shaped when we look at it in a coarser perspective than the other. So what I'm going to present now is the pretty simple, straightforward results from the logistic regression, first looking at a variable of any hyperoxic event, and then substituting any hyperoxic event for the number of hyperoxic events to see if we had a dose response, and then some projections on what the effect size would be from a hyperoxic event. And we found for the primary hypothesis that any PaO2 was highly significant, and that while some of the variables were the covariables were statistically significant in the univariate analysis, they were all highly significant in the multivariate analysis. And of course, the model maintained its significance. When we substituted any event for the number of events, the situation stayed the same. We still had a highly significant effect from, in this case, increasing numbers of hyperoxic events, and all the covariables were still significant. So what about the effect size? That's always important. You get 4,000 samples, you can have a lot of things that are statistically significant that aren't clinically relevant. Using a regression model, in this case the logistic regression model, you can hold some of the covariates constant and then see the effect of the ones that you change. In economics, they call this ceteris paribus, which means assuming everything else stays the same. Of course, it never really stays the same, but that concept of trying to understand a particular effect when you have a multivariate relationship. So what I have here is a table that has the predicted mortality in the PICU and the cardiothoracic ICU, the baseline mortality with none of the blood gas events, a typical median number of blood gases, and the median PRISM score, and these are the numbers. What happens when you get a hyperoxic event added to that with none of the other aberrant blood gas measurements? Well, it almost triples. So you can see there is not an insignificant impact on the mortality. Then the other question is, how do the other variables interact with this? So the next slide is the baseline now, where we have all the blood gas variables added in, and you can see if you had hyper and if you had a low oxygen and a high and low pH, that the effect is even larger. It's almost quadruple the size. This does not include a hyperoxic event. When you add in hyperoxic event, you get a 50% increase in mortality. This carries forward, in both of the units are essentially the same, although the step increases are a little slightly bigger in the cardiothoracic patients. So we met our goal of confirming, in this case we confirmed, the Ram-Gopal report, including the dose effect, and we believe this is the first confirmation of that. So now, what are our next steps? We really, instead of just confirming what someone else did, we want to look at the data more carefully and see if we can have some other insight into what's going on. For the blood gases, we want to look at the timing of them, the relative frequency of these aberrant events, what the best thresholds might be, maybe it should be 40 instead of 50 for hypoxia. And then the interaction among them, having a high and a low blood gas, for instance. And then we also want to consider SpO2, and we'll be looking at sequential organ failure during the course of this stay to see if we can tease out a reasonable possible cause of the effect. Thank you very much. This is my where I live in Southern California, up on a mountain, looking out at Los Angeles. And I didn't mean to make that go away. Looking out at Los Angeles, and it's a very nice view from up there. Not as nice as my hotel room here, I must admit, but still, it's pleasant. That's near my house, and it often isn't that clear. So I'm happy to hear any questions or comments or suggestions.
Thank you, Tom. It was a fantastic overview. Peter?
I think it's a very important topic to really stress out these negative side effects of hyperoxemia or in these patients. You did your analysis mainly based on the PRISM score, so predicted mortality. Did you consider also to look, like the BALA study, for example, the PARTY studies, into the application on these patients of the low proctative ventilation bundle, or did you not consider to take it in your multivariate model?
We did not we did not do that, but we will, I think, going forward.
Because it might be the question, is this really independent, or might be by chance some association between hyperoxemia and bad ventilation. So terribly difficult to ventilate, people get stressed, turn their fight a little bit more up. That's what we see. So that's my suggestion, to have to look at this as well.
Well, this is an observational study, and there's lots of associations between things, sure, and proving. We really need a randomized trial to prove yeah, some of these things. But we can in the next step, we want to drill down and try to look at, you know, the timing of when the gases are. If they're all right at the end of the life, that's very different than they're a reflection of desperate measures rather than the cause. Looking at the multi-system organ failure and the timing of the blood gases will give us that in the next stage.
Good. Next session.
Perfect from you. That's amazing. Thank you.
Yeah, thank you for your talk, Jan from Germany. I have one question to one of your slides where you showed the PaO2 below 100 was associated with a significant increase in mortality than predicted. How do you get that? So there was a pretty high mortality in the low range and a pretty high mortality in the yes, high range, and in between it doesn't seem so significant. How do we match that together?
Well, those numbers were, and that I didn't explain that very well. Those were the highest level in the U-shaped curve that I showed you. Those were the highest level PaO2. So those were patients that at the far end that never had a PaO2, say, above 75 in their whole stay or above 50. So I think then it makes more sense that that's their highest one. And the other end, we're talking about highest, we're looking at extremely high values. And the ones that are more in the middle then, that the trough was around 125, those in that area. So I think it's typical of the U-shaped things, and I think when you consider that it's the highest value rather than any value, it makes more sense.
Go ahead, Martin.
Thank you, Tom, for this great talk. Maybe I missed it, but you said at some point we do the arterial blood gas, so we put the A-line in only in the more severe kids. So probably there is some confounding by indication in your study. And confounding by indication means that the most sickest patient is the most likely to get the intervention, and it will skew your signal. So how did you take that into consideration? And how, for example, is there a practice variability among your faculty, that one is more liberal and one is more restrictive in A-lines, or because that probably, well, it does affect your outcomes.
Well, it's the amalgam of the very large faculty at Children's Hospital and their care. And if you look at why patients get high PaO2s, it's usually much more frequent when you have very, very extremely high FiO2s. But why whether one caregiver versus another created that, we don't know. We don't have anything in this analysis. We are going to look at multi-system organ failure, but again, that doesn't include the difference among faculty. Yeah.
Yeah, because I'm asking it because it's, as Peter said, it's a very important topic and it's a hot topic, and for sure there will be a signal. But at some point, I'm always asking: is this a marker of severity, or is this a true driver of severity and a true driver of outcome? That's
well, the one study that I commented on, and I think the PICU Oxy study will show that effect, is the one at admission, the SpO2s that are high, just above 95, on the day of admission had an effect on multi-system organ failure. To me, was convincing that the hyperoxia is creating the problem. But you know, I think the other study would be better.
I'm seeing my chaperone getting up, so
yes, and
have to get out of the way.
And my associate here.
I knew Professor Neighbour would ask some question that got me out of my seat. Martin, you're absolutely right about the confounding by severity of patients. I think that is true in the PICU. We have no reason to believe that it won't be, and we'll find that out on ongoing analysis. In the cardiothoracic ICU, mostly post-operative cases, they routinely come back with an arterial line in place, and I don't think that confounding will be seen.
Thanks, Ked.
I'll take the chair's prerogative to ask one last question
before
we move on. Again, very interesting presentation. So I think you heard a little bit about the cardiothoracic ICU. I'm particularly curious about the population with cyanotic congenital heart disease that was probably having low sort of saturation before, that would have post-operatively had much higher PaO2s. Was there an idea to separate that population out just because of that being so inherently different?
Well, it occurred to me that you're right. You would have one patient that before they had their surgery had a whole bunch of low PaO2s, and then after the surgery, to some degree, maybe high ones. And we did not look at pre and post surgery. That's a confounding thing that maybe we'll get at. We have the diagnoses. We could maybe sort that out.
That'll definitely be helpful to have. And what proportion of these children were on ECMO?
Why did we take that out?
What proportion of these children were on ECMO? Oh, exclude. Sorry, I missed that.
So, yeah.
Thank you.
I can't remember the number, but it was a relatively small number compared to all. We took out more because they had less than a day artificial ventilation than because they were exposed to ECMO.
Thank you so much for sharing this
My
wonderful
pleasure.
work with our team here today.
And no deference to the next speaker, but I have to go out and defend some posters too. They schedule them both at the same time.
Thank you, Tom.
Thank you.
The next speaker is going to be speaking on acute respiratory distress syndrome, response to high-frequency oscillation ventilation in a population of children with ARDS and according to its subtypes. And to give this presentation, we have Fabienne from Switzerland. Welcome.
Thank you. So thank you for this opportunity to present my study, or studies, sorry. as the title shows, and as you said, it's about ARDS and the analysis of its subtypes. So our main objectives were to explore the response to high-frequency oscillation ventilation in the children hospitalized in our unit, and to compare those responses according to its subtypes, direct versus indirect ARDS. So just a quick drawing. You can see the differences in between direct ARDS, which is mainly related or triggered by a pulmonary primary injury, like pneumonia, inhalation injury, and so on. Whereas indirect ARDS is triggered by a systemic insult or injury, like sepsis or burns or liver disease. Sorry. So it was a retrospective study performed in a single center at the University Hospital of Geneva. We included 64 patients with ARDS between 1999 and 2011. It seems to be a little bit old, but we still decided to go on with the study, as the way we ventilated the patient at that time hasn't changed much compared to the current recommendation and practice in our unit. We classified the ARDS subtypes, the children according to the subtypes, with 40 patients included in the direct group and 24 in the indirect group. And we had a couple of usual exclusion criteria. If you see the characteristics of our populations, you can see that they're really similar. The only difference is the hospital length of stay that was a little bit more longer in the indirect ARDS group compared to the direct group. And here you see the repartition of etiology of the direct ARDS. As I said before, it's mainly pneumonia, aspiration, pulmonary hemorrhage, and so on, compared to indirect ARDS, which is related to sepsis, oncology, and 24% of patients had liver disease. So what about our results? Here you see the evolution of the mean airway pressure over time. Let me just, So you see, sorry. If I can do both together. You can see at the start of the HFOV, the mean airway pressure will increase quite significantly. And then it stays like above the value that was on conventional ventilation, and it's followed by a slow and continuous decrease in this mean airway pressure. By the end of the HFO ventilation, the last value on HFO that you can see here on the graph, the value started to become really lower, and when the patient was back on conventional ventilation, it's interesting to notice that the mean airway pressure was significantly lower compared to the value before the course of HFOV. We looked at the PF ratio as well. You can see that once the patient started on HFOV, this ratio increased continuously throughout the course of this ventilation. And the last value on HFO was significantly higher than the one before the treatment. And again, the post-HFOV treatment was much higher compared to the previous one on conventional ventilation. And again, the same result with the oxygenation index. There was a slight worsening at the beginning when we switched the patient to HFOV, but then at the end of the treatment and when the patient was back on conventional ventilation, this oxygenation index was better than before. Very quickly, we also had a look on the PaCO2 to be sure that there was no worsening of the PaCO2 on HFOV, and as you can see, it was pretty much stable. So what about the direct and indirect ARDS subtypes? So we compared the two subtypes with the same parameters, and what you can see here that the mean airway pressure of the indirect ARDS started with the same value, more or less, on the conventional ventilation, but then it required much higher mean airway pressure on HFOV until 72 hours of treatment, where both reached the same numbers, and when it was back on conventional ventilation, direct and indirect ARDS required the same pressures. For the change of the PF ratio over time, it's interesting to notice that they both started around the same values, direct and indirect, but from 12 hours on, the indirect group had a much quicker improvement in the PF ratio, and this was sustained after the discontinuation of HFOV. In terms of oxygenation index, there was not much difference in between the two groups, a slight deterioration at the beginning, but it was expected compared to if you look at the previous slides. So in conclusion, the transition from our patient from conventional ventilation to HFOV was well tolerated, even though some patients required higher mean airway pressure initially. The HFOV seemed to be associated with an improvement in oxygenation, as shown by the improvement in PF ratio oxygenation index, and it allowed the PSO2 to remain stable. And when comparing the two subtypes of ARDS, we saw that the indirect group required higher mean airway pressure. They responded faster to HFOV, but they had a longer hospital stay. Thank you.
I have a question. My name is Sergey, United States. Do you combine high-frequency oscillation with the inhaled nitric oxide? Do you have experience whether or not you consider or have inclination to use it often? Thank you.
We had some patients in the core that had inhaled oxygen nitrics, but they were not included in the study.
Allow me just to comment on this.
Thank you.
Actually, we use nitric oxide only these patients if we have impeding right ventricular failure. So tamponade, if you want. No, there's not real data about this, you know.
Any other questions? While our audience is thinking about questions, in terms of the length of ventilation as well as the length of stay, did these outcomes, obviously it's a observational study, what do you think was a difference between the overall duration of ventilation, duration of ICU stay between these two groups?
So one of the possibilities is that the patient with indirect ARDS had more systemic issues. It was not just a lung pathology, so they required over-treatment of the rest of the organs, and that might be one of the reasons of their prolonged length of stay.
Martin?
So very nice data, congratulations. You showed the two phenotypes, direct, indirect, and there seemed to be a little bit of difference, but maybe in the end you conclude there's no difference and you just have to individualize it. So you mainly talked about the OI and the PF ratio, but at your summary you said that you could maintain CO2 in normal ranges. Was there a difference in frequency needed between the two groups, for example, or did you have to play with the power and the amplitude, or what?
To be honest, as it was a retrospective study, I don't have the answer. I'm looking at Peter, maybe.
He has to look at it. Yeah. Well, but again, very nice data. Congratulations.
Thank you.
I would like to thank all the three speakers for this session, and thank you for sharing your wonderful work with all of us today. And with that, we also have extra 20 minutes that we can take a break before the lunch symposia. So thank you everyone for joining us for this session.